Good morning to everyone. Good morning, good afternoon, or good evening to our participants from around the globe. Welcome to the webinar, Think Global, Act Local, Contributions, Patient and Family Engagement Strategies and Contributions in the COVID-19 pandemic. Next slide, please. This webinar is sponsored by the World Health Organization and is hosted today by the Canadian Patient Safety Institute, who are a collaborating center for the patient safety and patient engagement. My name is Helen Haskell. I am co-chair of the Patients for Patient Safety Advisory Group, which is a Patients for Patient Safety is a group of champions from around the world specializing in patient engagement and patient safety. Next slide, please. So the objectives of this webinar today are to engage webinar participants in thinking through patient and family engagement strategies that promote safety for patients, families, and health workers in the COVID-19 pandemic, to share innovative responses that have been used by Patients for Patient Safety champions in response to the new threats to safety posed by the COVID-19 pandemic, and to spread useful tools and resources. Our speakers today are Hussein Jaffrey, Sharon of Pakistan, Sharon Nettleton of Canada, Alex Adusei of Ghana, and Josephine Aklu of the United Kingdom. And we are also privileged to have introductory remarks by Neelam Dhingra, the World Health Organization head of patient safety and now head of the recently launched WHO flagship initiative, A Decade of Patient Safety 2020 through 2030. A few housekeeping details. All of your lines will be muted. We encourage you to use the chat function to send questions to the presenters or to interact with the host. If you have technical questions, please send them to Janet Bradshaw of CPSI. To use the chat, you can click the chat icon at the bottom of the screen. A drop-box menu will appear, and you can select names or select all from the drop-down menu. We ask that you send questions for the presenters to the entire group. And our U.S. Patients for Patient Safety champion, Marty Hatley, will be managing the questions for us, and we'll relay them to the group. We'll have time for about 1 or 2 questions after each presentation, and then we'll have a brief discussion at the end. The session will be recorded, and you can find resources and bios just under the gallery at the top of the screen, and those will also be put on the website along with the recording after the presentation. Thank you. Next slide, please. So our first presentation will be from Neelam Dhingra, the unit head of patient safety. Welcome, Neelam. Thank you. Neelam?
Thank you, Helen, for your kind introduction, and to the Canadian Patient Safety Institute for hosting this extremely important webinar of patient and family engagement strategies and contributions in the COVID-19 pandemic. My name is Neelam Dhingra. I'm the unit head for Patient Safety Flagship, as Helen mentioned, and on behalf of the Patient Safety Flagship, I would like to welcome you to this webinar. I've been coordinating and leading the patient safety work in WHO for the last 6 years, and before that, I was coordinating the WHO blood safety efforts for about 15 years. So I can say that my entire career is dedicated to safety in healthcare. WHO Patients for Patient Safety Program, as Helen mentioned, or in short PFPS, was established in 2005 and has been one of the most important strategic and longest activity in the history of WHO patient safety activities. And we really appreciate the Patient for Patient Safety champions, the advocates, for their commitment, the activities they've organized over the years, and their support for this very important program. PFPS Global Network has champions from more than 20 countries, and together with the PFPS Advisory Group, which Helen is, as I mentioned, is chairing, PFPS has been supporting WHO by shaping useful resources for patients and families on WHO patient safety initiatives such as World Patient Safety Day, the Global Challenge on Medication Without Harm and Hand Hygiene, and several other initiatives which have been heavily supported and led by PFPS. As you are aware that WHO World Health Assembly passed a resolution on global action on patient safety last year, and 2019 was a watershed moment for patient safety globally. One of the actions which the resolution asked WHO is to develop a global patient safety action plan. And for the last couple of months, we've been working on this action plan, and one of the sections of this action plan is fully dedicated to engaging patients and families for safer healthcare. And it's going to recommend and also propose a set of actions for different stakeholders, including member states, the governments particularly, whether it's Ministry of Education, Ministry of Health, and other governmental agencies, to healthcare facilities, to different stakeholders and non-governmental organizations, as well as civil society organizations, patient representative and patient organizations, and also to WHO, all levels and all the different parts of WHO. So we plan to organize a web-based public consultation on the draft Global Patient Safety Action Plan in July, August. And we'll make this announcement for this public consultation to all of you. And we would really appreciate your critical review and input on this action plan, which will lay the foundation for next 10 years, for the decade for patient safety, and for globally for all the stakeholders and partners to take action. In addition to recommending the Global Patient Safety Action Plan, the resolution also asks WHO to promote and support World Patient Safety Day campaign. And as you are aware, the World Patient Safety Day was established as part of this resolution to be observed every year on 17th September. And last year, the first World Patient Safety Day was dedicated to speak up for patient safety. More than 105 countries actually celebrated this day with lighting up monuments around the world. And the report of this day also will be available soon. And now been working on the 2020 campaign and also looking at how we can take forward the message of patient safety going forward. Could I have the next slide, please? So just want to bring to the theme for World Patient Safety Day of this year, which is health worker safety, a priority for patient safety, driven by the challenges which health workers around the world have been facing in their response to COVID. And with this theme, the slogan which WHO has proposed is Safe Health Workers, Safe Patients. And we very much look forward to your participation and your leadership and ownership at all levels around the world to observe and celebrate this day and bring the message of health worker safety this year so that we can assure safety of patients. Regarding patient safety during the COVID-19 pandemic and the response from countries, we also organized 2 webinars inviting frontline experts and policymakers and national representatives from our 2 regions. So we actually covered the Western Pacific region and the European region, and we are also going to work towards organizing a 3rd webinar for getting the experience and learning from experiences of countries and experts from the Eastern Mediterranean region. And we'll be making an announcement to this webinar as well once we are ready. So without taking any more time, I welcome you again for this webinar, and I thank you for your attention and hand it over to Helen again. Thank you, Helen.
Thank you so much, Neelam, for that very helpful overview of everything that's going on. Now we will transition to our champion speakers, the first of whom is Hussein Jaffrey, our Vice Chair at the Patients for Patient Safety Advisory Group. Hussein is also the chair-elect of the World Patients Alliance and is the provincial focal person on patient safety and quality for the government of Punjab. And he is going to talk to us about Pakistani patient safety groups working with the government of Pakistan to address the needs of the public. Welcome, Hussein.
Hi, everybody. This is Hussein. And first of all, thanks to Helen, Neelam, and CPSI for providing me this opportunity to share our experience from Pakistan. Can I have the next slide, please? Yeah, so we all know that the COVID-19 pandemic has affected billions of people around the globe and exposed limitations and deficiencies in all health systems. The impact has been particularly devastating in low and middle income countries due to relatively weak health infrastructure and fragile economies, and Pakistan falls into this category of countries. In 2019, the country was ranked 152 out of 189 on the Human Development Index. Health inequalities are high compared to the average South Asian countries. The COVID-19 pandemic has devastated the economy, and the country's health system is being hugely challenged. Pakistan initially took strict measures due to which the spread of the virus was under control. However, the situation got bad in the last 1 month since the lockdown has been eased, but fortunately the reported death rate are low as compared to many other countries. However, despite being a low-resource country, Pakistan has so far been able to meet the challenges of the COVID-19 pandemic. One main reason is the way the patient and community organizations have joined hands with the government during this crisis and provided a great example of collaborative work which other countries can learn from. So let me show you these figures, which are the current figures of COVID-19 in Pakistan. We have approximately 165,000 people confirmed cases of COVID. Out of this, 61,000 have been cured and 100,000 are still active. And the total death so far out of these 165 is been 3,229. And I come from the province of Punjab, which is a big province, a province with 120 million people, and our confirmed cases are 61,000 with deaths about nearly 1,300. Can I have the next slide, please? Yeah, so our lockdown was imposed in the country over 3 months ago. That has definitely helped in reducing the number of COVID patients in Pakistan. However, it is difficult for a low-resource country like Pakistan to implement the lockdown for an indefinite period of time. Therefore, the lockdown was eased, and especially before the government allowed the shops to open and public transport to run. However, unfortunately, a big number of people came out of the houses and did not maintain the required social distancing. And there was great rush and gathering at the bazaars and markets. Now the government has brought in a new concept called smart lockdown, in which the specific neighborhoods are put under lockdown where there are more cases of COVID-19. So we pray that things still remain under control in the next weeks and the months as well. Next, please. I just wanted to touch upon a very important initiative by the World Health Organization, especially the EMRO office. It is called Patient Safety Friendly Hospital Initiative, under which hospitals have to follow and implement patient safety guidelines. And this initiative has 5 domains in it, and one of which is patient and community involvement. So let me tell you one thing for sure, that one of the reasons for Pakistan to have done better with COVID-19 is because our patients and community have been very actively collaborated with the government to improve the situation on the ground. So let me give you some examples of how patient advocates and community organizations have come forward to help the government in a variety of ways in Pakistan. Next, please. So first of all, telephone helplines, patient organizations have collaborated with different universities and other professional organizations to establish telephone helplines for patients and families during the ongoing lockdown and this current isolation period. The objective of establishing these helplines is for patient and community members to call and seek psychological counseling and any other help that they need during this time of stress and isolation. One example is Alzheimer's Pakistan, who got together with Government College University and have launched a nationwide helpline for people with dementia and their family caregivers. Next, please. Patient organizations have been very active on social media during the current pandemic and have set up campaigns to provide their communities with advice and guidance on how to cope with the current situation. Facebook and WhatsApp are actively being used to create awareness and support ongoing updates on the COVID-19. Some patient organizations have formed WhatsApp support groups for patients and caregivers through which they are able to provide ongoing support to their communities and patients. Next, please. As health systems focus almost exclusively on the prevention of COVID-19 and the management of those affected, this is having a negative effect on other patients with non-COVID related health problems. These people are facing great challenges for getting the care they need. And an example of this is the patients with beta thalassemia, which is an inherited anemia. And these patients require ongoing continuous blood transfusion every month, sometimes 2 times or 3 times a month. So people stopped donating blood during this pandemic, and due to which there was a shortage of blood and patients were not getting the required blood transfusion. The Thalassemia Federation of Pakistan, the national umbrella organization of thalassemia charities, has set up an awareness and advocacy campaign through social, electronic, and print media. And they highlighted basically the shortage of blood for this group of patients. The campaign was extremely successful. The President of Pakistan himself and the Health Minister participated and held meetings, and following those meetings with thalassemia organizations, they have taken steps to ensure a constant and ongoing supply of fresh blood at the public sector hospitals through a donation campaign, which again is run by the government and through their health department's blood transfusion authority. Next, please. So access to comprehensive, appropriate, and simplified information about the diagnosis, prevention, treatment, and other services related to COVID-19 is vital. But information developed by health professionals tend to be difficult for patients and community to fully understand. So therefore, patient organizations in Pakistan have been very actively involved in the voluntary co-production and dissemination of information. And this information has supported government and healthcare system to convey accurate and understandable information to the communities. Next, please. Patients with disabilities and special needs are often ignored in times of humanitarian crisis like the current pandemic. And our previous experience of dealing with emergency situation in Pakistan and elsewhere as well show that the health system tend to overlook their essential requirements. To counter this, the Pakistan Patient Safety Network has advocated for patients with special needs such as mental illness, disabilities, and other chronic conditions. And as a result of this campaign, the health minister ordered that all patients with COVID-19 disease should be fully assessed and their special needs recorded and responded to. Next slide, please. The economic cost of COVID-19 is huge, and for a developing country like Pakistan, this presents daunting problems. The country remained under lockdown for many weeks, and most people experienced severe financial hardships. Those who were informal employment and paid on daily basis, such as laborers, construction workers, carpenters, shopkeepers, rickshaw taxi drivers, were the worst hit. So many have been unable to afford food during this time. The Jahandar Society for Community Development is currently working with the city government Lahore to establish a network of charity organizations to distribute food ration packs to daily wage earners. To this date, the network has already distributed food ration to over 125,000 families, and which basically comprising of over 750,000 people. Some patient organizations, such as Alzheimer's Pakistan, are providing food ration packs to needy patients in their own communities. Similar public and private networks comprising of patients and community organizations and local governments are established all over the countries in all the cities of Pakistan. Next, please. The economic downturn has also affected patients with chronic conditions as they are no longer able to pay for their medicines. Providing people with medicines they need for free is a huge task, but patient organizations are playing their part again. So let me give you an example of Thalassemia Society of Pakistan that has started working on providing free medicines and treatment to all the 33,000 patients with thalassemia registered at their organization. Next, please. And I would also like to highlight another important patient initiative of distributing face masks, especially to elderly and non-COVID patients with their families. So, for example, Alzheimer's Pakistan, in collaboration with Taiwan Alzheimer's Association and Jahanda Society for Community Development, are distributing face masks to people with dementia and their families. A large number of face masks have so far been distributed under this initiative. The Prime Minister Imran Khan, you can see his picture over there, has established a voluntary task force to assist the Pakistani government in providing food and essential commodities to the areas under strict lockdown. So far, around 1 million people from all walks of life, including patient advocates, have joined hands and joined this task force and are working alongside armed forces and civil administration to deliver people the food and the essential supplies that they require during this time. So in conclusion, as I already mentioned before, despite being a low-resource country, Pakistan has so far been able to meet the challenges of COVID-19. And the best part is that the reported deaths are low as compared to many, many other countries. And one of the main reasons is the way that patients and community organizations have joined hands with the government during this crisis and provided great examples of collaborative action which other countries can learn from. Thank you very much.
Thank you, Hussain. Marty, I believe we have time for just one question for Hussain. Could you give us a question for Hussain from the chat box, please?
Hussain, people are really resonating with your presentation about the importance of this being a humanitarian crisis for people who are disabled. I don't really have a question except just to pass on the fact that that is really resonating with people in the chat box. Do you want to say a bit more about what you've seen to be very effective there in terms of raising the awareness of that as a humanitarian crisis?
Yeah, I think what my experience has been that, you need just, a few people to really come forward and start the initiative and to just take that initiative. And like in our case, there were a few people, in every aspect, and they came forward and they started working. And when the government saw the benefit of the community getting involved, patient, advocates getting involved, they also collaborated with. So, rather than these patients working in isolation, the government working in isolation, I think both of these groups realized the importance of working together. And once that happened, and the government really provided all the sort of support that you needed, especially during the lockdown and other times as well. They were given special passes, they were given special letters so they can move around and, communicate with other patients, and they were facilitated as much as by the government. And so my take-home message would be to people to really come forward and start working and get in touch with the local authorities, and with their help, they can reach, really, they can have very, a long reach. They can reach people they would have otherwise not reached.
Thank you, Hussain. That was terrific talk and terrific message.
Ellen, we also have a request in the chat box for panelists who are not speaking to mute to minimize background noise.
Okay. Thank you, Marty. Now we're going to move to our next speaker, Sharon Nettleton, who is a longtime champion for Patients for Patient Safety Canada and former co-chair of Patients for Patient Safety Canada. Sharon's had a long career in health services planning and policy, over 2 decades in 2 provinces, Ontario and Alberta, where she has worked with patients, families, health leaders, planners, policymakers, and care providers to implement change and improvements together. And as a reminder, the bios are in the box at the top, so you can read more details if you would like. Welcome, Sharon, who is going to talk about tools and strategies for supporting the homebound elderly in Canada.
Thank you, Helen. Hello, everyone. It's a great opportunity to join you today, and I feel very humbled. Sharing with you today from my little corner in the province of Alberta and the city of Calgary and my neighborhood of Scarborough. Next slide. I'm going to talk to you about an initiative that 3 of us in our community started several years ago, about 6 years ago, and it was really a way of trying to keep seniors, many of whom are quite elderly, in our community connected. Next slide, please. When COVID-19 hit our province, and particularly our city in mid-March, we saw seniors being impacted greatly. Our neighborhood is very small. There's about 300 homes. There's 1,000 people living in our community. And this is one community in a city of over 1 million. And there's probably getting close to 200, about 160, 170 persons in our community that are 65 and older, many of whom are very elderly. I think the oldest in our neighborhood is 97. And many of these seniors don't have family living close by. Some don't have family even in the province. So 6 years ago, these 3 of us set up this, what we deemed a coffee clutch. It was a way of seniors connecting about 4 or 5 times a year at least in an organized fashion, and especially important during the winter months. And our winters here in Canada, and particularly in Alberta, are quite long. So when COVID hit mid-March, we already had in our community a way of quickly getting a hold of and communicating with persons at risk, and especially our seniors. So, and we wanted to demonstrate quite a few things. One is we wanted to be able to connect with seniors and let them know that we cared about them, that we were worried for them, that we had some key information we wanted to share with them, and we wanted to stay connected to them during this period. And of course, when COVID broke out, we weren't sure, and we still aren't sure how long it's going to last and what the implications are, and particularly for seniors. But in our city of Calgary, we saw quite a few seniors' residences being severely impacted by COVID. So we knew, as the world knew, that seniors were, and people who were immunocompromised were greatly at risk. So we had this connection into our community through this coffee club, or coffee clutch if you like. We also have a community newsletter that we could quickly communicate to people in the community. The information that we wanted to communicate was especially about the lockdown, because certainly our city was in isolation and lockdown mode. Schools were closed, places of work were closed, with the exception of essential services, recreation, places of worship, and again, no one was sure for how long. But we really didn't want our seniors leaving their homes and trying to go to these places that had normally been great places of support and socialization. So we reached out immediately, and we had a communication team. We phoned out to our seniors and others in the community who we knew were at risk. And at the same time, we reached out to people in the community, anyone in the community who wanted to volunteer. And the volunteering was really a buddy system, buddies plus a backup with a central command, if you like, we knew leadership and some coordination was involved. But the care, compassion, the communication, and the commitment of a team we thought was going to be really important to us. For some of the seniors, and especially those who were quite elderly and probably more at risk than others, we found, and I'll speak to my own experience with a 95-year-old senior who I'm a buddy to, we found that information, even within their own home, was somehow compromised, ways of connecting to their own friends and to their family, because information wasn't collated. So I'll speak again to my own experience with my 95-year-old buddy, and we found it important to collect her information. And for the most part, we did this on the phone. There were a few face-to-face visits, but I didn't want to compromise her, so we had porch-side meetings at a distance. She would leave information for me on her porch. I would take it home and collate it for her so that she had multiple copies in her home by various telephones of information that she would need if there was an emergency, ways of contacting her family, ways of contacting her primary care physician, ways of contacting her pharmacist. And so this was an important means, if you like. It was a resource sheet, and we found it important not just for this individual, but for others in the community. That personal contact sheet also included medical directives. When I talked to my buddy about where her wishes were in her home and whether they were accessible, easily accessible, should she become ill, and she actually did become ill in the first month of COVID. And so there were many medical visits to her home, and she had a few visits to the hospital. Fortunately, she's in her home, and she remains safe, but that connection sheet and the information back to her family, her friends, and her primary care physician and her pharmacist were key and critical. We maintained this approach over the 3 months that we've now been in a COVID experience in our pandemic. Communication, commitment of a team, and constant expressions of caring and compassion. And that caring and compassion is in many ways. It's our team of over 50 volunteers in our community are shopping for our seniors. They're providing meals. When it's safe, they're taking them to essential appointments or making telephone calls for them. We're finding that for some of our very elderly seniors, hearing is a problem, and even speaking on the telephone can be a problem. So where they're used to your voice, your tone, your own intonation, and the pausing, that information can be conveyed from them to you and then you to another service provider, much more efficiently, much more effectively. Our city is currently in the second stage or second phase of the pandemic and reopening. And this is a particularly difficult time, if you like, because the weather's nicer, people are out more, and there is that issue of forgetting that COVID exists and wanting to be physically closer. We are continuing to communicate key messages about hand washing, about social distancing, and the wearing of masks when you can't social distance. The wearing of masks was something very early in our community that volunteers began sewing, and through our Coffee Clutch and community newsletter, we put information out that anyone in the community could have access to masks. We would deliver them, instructions about how to wear the mask, instructions about washing. These were reusable masks, and how they needed to be handled safely and properly. There were also other key messages. We wanted to ensure that that everyone in the community was safe, from the very young, from young parents, middle-agers, and our seniors. Important to get outside, even though our city and our community was in lockdown. Very important to get outside where we could, get exercise, get fresh air, that everyone had access to food. And again, through the volunteers, we were doing shopping and picking up pharmaceuticals, essential medications for those that needed it, but we were doing it in bulk, and we were doing it safely, so particularly those who were at risk did not need to expose themselves unduly. There were some other important initiatives when our buddies were making phone calls and where they could safely, doing porch side visits, keeping up that interaction, and again, reiterating important messages such as hand washing, social distancing, wearing masks when they needed to, and getting outside and staying both physically healthy as well as mentally healthy. You know, our city, the city of Calgary and the surrounding area, we've had probably the majority of COVID cases and the majority of deaths in the province. So it's certainly been a serious situation here in Alberta, and particularly in the city of Calgary to begin with. Our population in the city, over 1 million. There have been 152 deaths in our province and over 100 deaths in the city of Calgary. About 80% of those deaths have been to senior citizens. The spread, and especially the senior citizens most impacted early on, were seniors living in care facilities. And we found out very early on that some of that spread was occurring through healthcare workers and through others. And this has been particularly concerning to everyone, not just in our city, in our province, and in our country, where we understand the impact, not just of death, but also the impact of the illness and how it's impacted healthcare workers, especially, seniors especially, and families. Where isolation...
Thank you, Sharon.
Thank you.
No, go ahead. We have to wrap it up very quickly.
Yeah. I want to say there's lots of opportunity in the future to talk about spread, and particularly in communities where there are different racial groups, different income groups, where workers are having multiple jobs and living in denser situations, living conditions. So that's a concern to us all moving forward, particularly here in Canada. Thank you.
Thank you so much, Sharon. That's great. And I see that Janet has posted the contact sheet as an example of the contact sheet, which will also be available in our resources. That's a terrific resource.
Helen, Marty, I know we have to move on, but Sharon, if you could look in the chat box, there's questions there about the role volunteers play in helping get advanced directives in place. And also whether you have advice for volunteers about how they can help someone who's afraid to go to the hospital but might need treatment. So if you could maybe respond to those in the chat box, that would be great.
Thanks, Marty.
Yes, and I think we will skip the questions, the verbal questions for now, but we will try to have some at the end. Let's have the next slide, please. We're going to move on to Alex Adjusay, who is a longtime Patient for Patient Safety champion in Ghana. Alex is Executive Director of the Women's Hope Foundation, an NGO advancing women's and girls' rights and justice in Ghana. He's a researcher, facilitator, trainer, and consultant, and has over 15 years' experience as a human rights advocate and community health worker. So, welcome, Alex. Alex, can you take yourself off mute?
Hello.
Hello. Yes, now we hear you.
Great. Thank you, Helen, and good afternoon, everybody. Thank you for your introduction. My name is Alex Aduse. I'm presenting on challenges and solutions in responding to COVID-19, which is the coronavirus in Ghana. So, next slide, please. So this is the overview of the situation, the COVID-19 situation in Ghana. As of 17th June 2020, 13,203 people in Ghana have tested positive for COVID-19, and 70 people have died, and 4,548 have recovered. The majority of the people infected in Ghana have mild or no symptoms. A very small number have required hospital treatment. The majority of the cases have been in the Greater Accra and the Greater Kumasi, the two areas where the bulk of economic activities in Ghana take place. We have 16 regions in Ghana. So the Greater Accra and then the Greater Kumasi is the two major regions. So the government of Ghana has put in place various national public and economic measures to prevent and contain the virus. The government is using the 3 method, which is trace, test, and treat, to identify and isolate infected persons to stop the spread of the virus, which is the person-to-person spread. Drones are being used to hasten transport of samples to laboratories, so confirmed cases can be quickly identified, isolated, and treated. Domestic products of personal protective equipment, such as nose masks, hand sanitizer, has been scaled up. Scientists at the University of Ghana have also successfully sequenced genomes of the virus responsible for the COVID-19 from 50 confirmed cases to strengthen surveillance for mutation of the virus and to aid tracing the source of infection in people with no contact with confirmed cases. All educational facilities remain closed as I'm speaking with you now. Public and large gatherings remain banned, and wearing of face masks has been made compulsory by law to reduce the person-to-person spread. So as I'm talking with you now, the government is easing some of the restrictions. Giving 100 people to go to church and other public gatherings. Next slide, please. Next, please. Hello? Hello?
We can hear you.
Okay, great.
Yeah.
So,
is this the right slide up?
Okay, right. So the negative impact of the COVID-19 on Ghanaian people. So in Ghana here, people infected with COVID-19 and their family face stigmatization. It's a serious matter in Ghana here. Those with COVID-19 is facing stigmatization, and people are isolating and rejecting them from their communities. Societal norms coupled with the misconception and misinformation about the pandemic and lack of resources has increased vulnerability, because people the misinformation about the COVID is going phenomenal in Ghana. People do not know much about COVID-19, but the government is trying to disseminate much information on media for the people to understand the COVID-19. So the government intervention do not adequately cater for marginalized people who live at the edge of our society, which is in our communities. This includes women and girls in rural and urban slums, street girls, women in informal economy, such as vendors and caregivers, people with disability, those living with HIV and other chronic illness. These people, the interventions, is not adequately cater for them. In deprived communities, there is inadequate access to facilities such as water, soap, sanitizers, and to the health facilities. The most vulnerable and poor people cannot afford the face mask, which has been made compulsory, as I mentioned. The self-employed, particularly market women, hairdressers, petty traders, and street vendors have been hardest hit by the economic consequences of the lockdown, because the business of these people was, restricted. So there was no, opportunity for them to engage in their trading. So this COVID-19 has, hit them very much. And the incident of intimate violence during the period of lockdown and restriction of movement has been alarming. There are a lot of reported cases on violence against women and girls, rape and other things because of the lockdown. Next, please. The negative impact, I continue with the negative impact. There also Ghana's economy is very poor, and then the health system is weak. As we all know, Ghana is one of the sub-Saharan Africa countries in Africa. So restrictions of movement has also reduced community interaction. People cannot interact, so it has reduced their interaction. Sexual and reproductive health and other health services have been also diverted because of the pandemic, leading to increased mortality and morbidity. And also the HIV and other illness because of the pandemic. The attention has been diverted to COVID-19. Leaving this aside, restrictions on movement have also decreased overall access to food supplies and markets, and have also increased prices of food, because here I'm speaking with now, the food prices have increased because of the COVID. Increased rate of malnutrition and starvation among marginalized group is also alarming. School closures can also increase and escalate inequalities and vulnerabilities for children, and it can also increase the likelihood of early or forced marriage, because this lockdowns, restrictions, economic hardship can lead, adolescents to premarital sex and other forced marriages. Gender-based violence, like I mentioned before, is also alarming, and adolescent pregnancy is also, the rate is increasing. Next slide. Okay, as patient safety champion in Ghana here, I developed a small project in partnership with two civil society organizations, like the Women's Hope Foundation and also pharmacists, to create awareness and educate people about the simple and effective things we all can do to reduce the risk of infection, that is from person to person and those around us. We conduct awareness raising and educational campaigns on COVID-19 prevention and control in local and in our local communities and radio stations at the grassroots level. Targeting our target group was, people at risk, those living in the street girls and other people with vulnerabilities. So the COVID, we also translate compressed COVID-19 information that is being shared by the government and public health. Because Ghana here, we use the English language in communicating in our radios and other things. But our local people, most of them do not understand the English language. So we translate the information shared to them in our local language for them to understand the COVID issues better. We also demonstrate the proper ways of hand hygiene, like how do you use sanitizers, how do you use running water and soap. We also produce and distribute free alcohol hand based or based on World Health Organization recommendation on local production, because World Health Organization has published local based, how you can develop a local based alcohol sanitizer. So we have done that and then given to people who cannot afford it in our communities. So I disseminate the following information. That is for people to clean their hands regularly with alcohol-based hand rub or soap and running water. Cover their mouth and nose with their elbows if they want to cough or coughing or sneezing. Avoid handshaking. Also stay home if you are not sick. Avoid loud, social gathering. Wear a nose mask which has been made compulsory when you are leaving from your home or when leaving home. Next. My intervention is that is the purpose or the objective I set to do this kind of activity is to save people's lives, save patients' lives, save our people, especially those in rural areas who do not have access to the internet, the information the government is sharing, for them also to understand what is going on. So purposely to save their lives, improve patients and help and provider safety during this COVID-19, and also increase patients' knowledge, skills, confidence on their health right during this crisis, because there are a lot of instances, because when this COVID-19, outbreak, the government announced this outbreak, people going to hospitals were, most of the hospitals were rejecting people because of the COVID-19, fear of panic, and then also fear of contamination, fear of infection. So their rights were abused. So the purpose also was to increase adequate, accurate, relevant, and accessible information on COVID-19 prevention and control measures to our people, for them to prevent themselves from infections and their loved ones. Okay, thank you very much.
Thank you so much, Alex. Our next, we're going to save the questions for the end, or you can ask Alex questions, and Alex, if you could respond in the chat to people. Our last speaker is Josephine Aklu, who is another longtime patient champion who went back to get her PhD after the loss of her daughter to patient safety issues over 2 decades ago. Josephine now works at King's College London as a diversity inclusion lead for the Applied Research Collaboration in South London. Welcome, Josephine. She's going to talk about disparate communities in London.
Thanks very much, Helen, and great to be having an opportunity to participate in your webinar. So I'm going to bring you some perspectives from where I'm based in the UK, and particularly in respect to an event I had in London. The title of my presentation is about the impact of COVID-19 on diverse populations in South London. So where I'm based, the population is very based, and there are some quite high pockets of social disadvantage and deprivation. And the community around the university where I'm based is a high one, a high multi-ethnic, multiracial population. And so in my presentation, what I'm really trying to do is build on themes that have been, that I put in the recent opinion piece that I wrote, Being Heard, Not Seldom Heard, Democratizing Research with Diverse Communities During the COVID-19 Pandemic. And I guess the title is really putting up a challenge to the types of models that we've been using for a long time around patient and public involvement, or patient engagement and patient and family engagement, and really just trying to raise these issues about these models need to change, and the COVID pandemic highlights this. And we particularly need to pick up issues of discrimination. And I think that what I also tried to say in this opinion piece was that some of the debates that are taking place in global health research, which kind of highlight the need to move beyond neo-colonial models of research to more equitable models, because of the health inequalities that are taking place in low and middle income countries, but which actually the research tends to benefit those in high income countries. What I was really saying is that those debates are actually very relevant in the UK because of the health inequality. So if I could have my first slide, please. So with COVID-19, as many people will be aware, it's exposed many of the stark disparities in mortality that are taking place, and health inequalities. And in the UK, we've seen these for particular groups for Black, Asian and minority ethnic communities, people with disabilities, those on lower incomes, those living in the most deprived areas, care home residents, and those in the poorest health are some of the groups who are most likely to be impacted. And these were the groups that were already facing considerable health inequalities, and there's now a real fear that these inequalities will get worse. And given that, that the mortality figures for COVID-19 are now about 42,000 in the UK, then there's good reason to be concerned about the impact on particular groups. And so people from a Black ethnic background are at the greatest risk of death for COVID-19, more than any other ethnic group. Black men are 3 times more likely than white men to die, and Black women are more than twice as likely to die as white women. If you adjust for socioeconomic factors, geographical location, this partially explains the increased risk, but there still remains, even after you adjust for that, there still remains twice the risk for Black males after this, and around 1.5 times more risk for Black females. Another study has recently highlighted the risk for South Asian people who were found in a more recent study. They were the most likely group to die from COVID-19 after being admitted to hospital, and diabetes was a significant factor in that. So these statistics really kind of highlight some of the issues about inequality, and I think that some of the stats around people on lower incomes or living in socially deprived areas are also very stark as well. In the UK, at the height of the pandemic, in some of the most deprived areas, if you looked at the age standardized mortality rates of deaths involving COVID-19 in the most deprived areas of England, it was 55.1 deaths per 100,000 compared with 25.3 deaths per 100,000 in the least deprived areas. Again, in Wales, the most deprived areas had a mortality rate for COVID-19 of 44.6 deaths per 100,000, which was almost twice as high as the least deprived area of 23.2 deaths per 100,000. So inequalities with COVID-19 are clearly stark. So if I could go to the next slide, please. And so really what I'm saying in the paper that I published is that we need to think about the models of engagement that we're using, because some of the groups that are the most affected by COVID-19 are the groups who are the least likely to be involved in the design and implementation of research. And this is causing debates at the moment because obviously there is a whole rush to do COVID-19 research. And all of the evidence shows that if you involve people in the research, if you involve the public in research, then you get greater impact and greater benefit. And yet the groups who are most affected by COVID-19 are not involved. And this kind of inequality in terms of engagement and involvement basically reflects wider patterns of public sector involvement, which show that those most likely to be involved are older, from white ethnic groups and higher socioeconomic backgrounds. And so this context exists despite long-standing calls for more equal partnership models to involve diverse groups in research and healthcare practice to strengthen the benefits and the impact. And this particular context, I think, has a lot of implications for patient safety, as Black, Asian and minority ethnic groups and other disadvantaged groups are more likely to be harmed and face discrimination, and yet they are not being involved in the solutions to the issues. So the next slide, please. We had a community Zoom event in April to try and give some of those groups who have little voice an opportunity to talk about the impact of COVID-19. And the findings from the Zoom event were fed into a parliamentary submission there was a call for evidence of impact from groups covered by the Equality Act, which affects groups across the protected characteristics. And the protected characteristics are to do with age, disability, gender reassignment, race, religion or belief, sex, sexual orientation, marriage and civil partnership, and pregnancy and maternity. And these are protected characteristics because these groups will often face discrimination. And we put this Zoom event on at very short notice. And many people would normally say, oh, well, you know, you're trying to involve groups that you don't often see, and therefore you're not going to get those groups at short notice. But our event was sold out within 48 hours. And you know, this indicated that it's not that groups are hard to reach, and that they don't want to be heard. Of course they want to be heard, but the structures are not actually enabling those voices to come through. So we heard a lot we heard some key themes. We heard a lot about maternity and pregnant women as a very vulnerable group, facing fear and isolation and not having the same birth choices. But there were particular concerns raised by doulas, who are like community midwives who can support a pregnant woman right the way through their pregnancy. And what the doulas were saying is they were talking about, you know, examples which they had seen of verbal, emotional abuse of some Black, Asian and minority ethnic women, which they perceived to be driven by racist attitudes. And this evidence was important because at the moment, Black women are 5 times more likely to die in childbirth in the UK than white women. And there's some real concerns about that now. And often we're not seeing the discussions about racism because the groups who are affected are not getting the opportunity to talk about what the issues are from their perspectives. And so those issues are not getting addressed. We also heard from BAME groups who, you know, clearly they're at higher risk from the virus, who said that they were fearful of attending outpatient hospitals, or they were fearful of going with other symptoms, like cancer symptoms. And, you know, again, because BAME communities are disproportionately affected by underlying health conditions, this is really worrying if they're not going to be attending their appointments. They talked about, you know, not wanting to go and get medication or, you know, their blood tests. And what this kind of revealed actually is that there's quite high levels of distrust in the healthcare system in some parts of the BAME community. And if that distrust is not addressed, given the impact of COVID-19 on these groups, we're going to see even more stark inequalities emerging. We heard from people with disabilities and learning difficulties, and they were worried about discrimination that they would face, and they talked about, you know, the fear that they would not be treated fairly in terms of getting access to resources and ventilators. And there's already plenty of evidence to show that, you know, people with learning difficulties are more likely to be affected by patient safety incidents, for example. Other vulnerable groups were, you know, those facing digital exclusions, which was preventing many vulnerable people from accessing primary care and even, you know, from being able to claim their benefits. And then, you know, there were lots of groups that, vulnerable groups that were affected by the loss of face-to-face services. And we had mental health service users who talked about the impact on them of the sudden closure of the services and not knowing where they could go to be able to access the 24-hour emergency lines. And, you know, this is worrying, particularly when you think again about some groups, Black, Asian and minority ethnic groups, are much more likely to be subject to the Mental Health Act, so much more likely to be detained in hospital. Again, LGBT plus groups have higher rates of poor mental health, they have worse access and therefore are likely to be affected by the closure of services. So it was really important when we had this Zoom event to be able to try and give voice to groups who are being disproportionately impacted, who have higher levels of health inequality, but current models of community engagement and involvement that we are using are not allowing those groups to be involved in addressing the issues. So if I could go to the last slide, please. So what actions can we take? So I think a real starting point with our models of community engagement and involvement is that we need to make conversations about equality, diversity and exclusion central to discussions about patient and family engagement and involvement and safety and quality improvement. And, you know, this type of discussion will be relevant to probably all Western countries where some of these models of engagement, which don't include diverse communities, are very prevalent. And I would argue that, you know, the WHO can take strong leadership on this in you know, picking up this issue about equality, diversity and inclusion in their engagement models, and sort of taking a leadership role in saying how that should work and how that could work. We need to look at EDI, equality, diversity and inclusion. We need to look at it, how to address it in the structures of our work. So it's not just enough to look at small models of PPI without actually looking at our institutions and actually looking at both how our healthcare organisations are impacted in terms of both patients and professionals, because certainly what we've seen in the UK is the disproportionate impact of COVID-19 on Black, Asian and minority ethnic health professionals. So there's a real issue there about diversity and inclusion. And I think that, you know, if we are going to develop projects, we need to make sure that there is diverse representation and leadership in all the projects and speaking engagements. And lastly, I think with the COVID-19 pandemic, we really need to democratize our research spaces. Again, these are areas which are not diverse, and you know, there have been quite a lot of discussions now, not least in the context of the Black Lives Matter, about institutions that do not represent you know, for example, Black, Asian and minority ethnic groups. And so we need to go bigger than the kind of PPI to kind of look at how research spaces operate and who gets to be involved in research, both as academics, but also how we recruit research participants, because often the participants that we are recruiting are not from diverse communities, and also, again, you know, getting diverse involvement in the partnership of conducting the research. So I'm going to stop there. Thank you.
Thank you, Josephine. Thank you very much for that really interesting presentation. So we are about 10 minutes over. I appreciate everybody sticking with us. It has been quite a challenge for our presenters to fit this enormous amount of information that they have into the tiny time slots they were given. So what I'm going to suggest is, I know Neelam is very busy, if she wants to go ahead and give her closing remarks, and then anybody who wants to and is available can stay on for a discussion for a few more minutes. So Neelam, over to you.
Thank you, Helen. Many, many thanks to all the presenters. Excellent, wonderful presentations and great opportunity to learn. All panelists, Helen, Hussein, Sharon, Alec, Josephine, Marty, and also Iona, Janet, and Marky in organizing it. So it's a wonderful initiative, and I really welcome and appreciate the leadership of Helen and Hussein in arranging it and taking it forward, and for Iona and Janet to give the key contribution and playing a key role as a WHO collaborating center for patient safety and patient engagement. So as I mentioned in the beginning of this webinar, that PFPS has the longest history in WHO Patient Safety Initiative since its launch. We believe patients as true partners, and we'll do everything possible to increase the power and influence and voice of patient families, I should say, in improving patient safety. The vision which WHO has is promoting and advocating the model which PFPS Canada has demonstrated, and several other countries actually, where they are each province and each country has a patient for patient safety network, so that patients from different walks of life could actually connect and share their experiences and contribute to improvement of healthcare systems, particularly improvement in patient safety and broadly quality and better health outcomes. So coming to the World Patient Safety Day, the theme of this year, as I mentioned, is health worker safety as a priority for patient safety. And truly speaking, the safety of health workers and patients is really two sides of a coin. And that's why, it was very pertinent. I know some of the people had reservations about it, coming from thinking that it is not really putting the patient in the center. But I think if you look at from the point of view of that only when we have safe health workers, they can actually provide safe care. So it's really truly one of the key domains of patient safety. And it will be great that PFPS could work with hospitals, institutions, and governments to raise the awareness of patient safety and the role of patients, and particularly for amplifying and drumbeating the messages related to the World Patient Safety Day of this year. And I particularly want to thank Canadian Patient Safety Institute for taking forward the work and the entire work of WHO patient safety and patient engagement in a very exemplary manner, and for strengthening the role of patients and partners in safety. I want to thank all the participants of this webinar for very insightful comments, and Marty for really managing the questions very well. I know the time is limited, but it's really very, very important to get your feedback and comments so that we can, when we are developing our strategies for patient engagement, we keep these important, insightful feedback into view, particularly when the Global Patient Safety Action Plan is actually being drafted. So I think it's the right moment for us to get your advice into this direction. So with that, I would like to wish everyone all the best for health and safety, and then back to Helen. Thank you so much indeed.
Thank you, Neelam. Thank you very much for that summary. And also here is our resource page. I wanted to mention that before we start on the discussion. All of our speakers have had been featured in the British Medical Journal Patient Perspectives or on the Canadian Patient for Patient Safety website. So if you want to look at those, BMJ has been very supportive on this, and of course the Canadian Patient Safety Institute also has. So those resources are here, and more complete list of resources will be posted on the web page or can be downloaded from the drop-down menu at the top of your screen. And I see we have a poll in the chat box about what do you think the learning objectives for the session were met. So if you could please fill that out, we would be grateful. I don't know how many people we still have online, but I am thinking that maybe we could take 10 more minutes for discussion if people were interested. One of the questions that I saw go by, Marty, was that we had not addressed telehealth, and I'm wondering if that is an issue for any of our speakers.
Helen, we got into the need for telehealth a little bit. People were commenting on how important it was to have somebody be an advocate for especially people who have disabilities or inability to communicate. So I think that could be an entree to it. We also have just a very practical request for the slides. Okay. Will people be able to get the slide presentation?
Yes, that will be posted as well. The slides and resources and bios and recording will all be posted on the CPSI website. And I think we will send, I assume, send an announcement of that to all the participants. Is that correct, Joanna or Janet?
That's correct, Helen. Will be posting that and sending an email notification to everyone who registered for this session, whether they were able to join us or not, once that's posted.
Great,
thank you. So I know there's been a lively discussion in the chat box, Marty. Is there anything from that you want to bring to the group?
Well, you've put telehealth on the table. I think that's a really good one, Helen. It didn't come up, you're right, directly, so it would be good to do. And then the other issue that I think is kind of related is visitation. How are people coping, you know, especially those of us who are supporters of patients when we can no longer visit and we have loved ones in the hospital. Also, a question came up about the fear that people have of going to the hospital now and delaying treatment because of that fear. That was directed to Sharon at her comments, but I think it could apply to any of the presenters. Those are kind of the things that me.
I mean, one of the things that strikes me about telehealth is I think one of the things that came across quite strongly in our Zoom was this issue of digital exclusion. And how many different groups actually, I kind of feel that maybe before the pandemic, there were more assumptions being made about how easy it would be. Maybe there is something about how the pandemic will raise a discussion about participation online, you know, who it empowers and who it doesn't empower, because clearly a lot of stuff is taking place online now, and maybe it could well be that a lot of people say they're empowered by it, and I do think there are some benefits, but there have been a lot of stories about people who haven't coped so well and have been digitally excluded, and those are probably the people that we're not going to hear from. So I do really think there is something there. Then there's been a lot of people who haven't been able, because all the funds, the benefits and everything have all switched suddenly overnight. People have to do everything online. And I do think this has had a really big impact. Homeless people, and, you know, we heard about people with disabilities just managing to use, you know, just in terms of the flexibility of use with their hands and everything, to be able to kind of use this digital stuff. So I really do think there's going to have to be more thought to what the issues are on that moving forward.
And Josephine, to your point, I would say more research. I mean, there's kind of this rush to do it, and we really don't know where it works well and how. And I'd love to see real people involved in designing that research. Your comments really struck me that way.
Absolutely. I think that's really kind of key to my presentation, really, that we got to democratize, you know, we got to democratize the whole involvement and research process, because particularly to enable those groups who are really being affected to get involved, because otherwise we're doing research to people, and that doesn't mean that it's going to address the needs of those groups.
So, Josephine, we have a question for you asking how you reached out to these diverse communities that you had on your call. Do you have any tips?
Some of the things, I think it's actually important to have an action focus. So I think sometimes in the research community, you know, we need to think about who benefits from that whole process. And I think that using kind of community participatory with an action focus is very important for people who are participating. They feel that actually something's going to come out of it. So that was one thing. We were feeding the results in to the parliamentary submission. And so I think people felt that, you know, we were not just listening, but we were going to actually do something with those results. Secondly, there was something about your contacts and your networks. And we had done quite a lot of work internally, and we have been doing quite a lot of work internally to build our database so that we have people on the database who are also from a range of diverse groups. So in organising this very quickly, we were able to have those contacts. Three, in terms of overseeing and sharing that, I think it's important that you can build trust by having people involved in the organisation who also can reflect the diversity of the communities you're trying to reach. And I was chairing the event, and I had other people who were also reflective of the diversity of the community. So I think I think that is important in engendering trust. I think those are some of the tips that we used.
This is Hussein Marty, and I think I wanted to say about use of social media. I think this social media has really helped us, the patient community and the other groups to really reach our target audiences, and especially in the developing countries where the scope of telemedicine is not very good or very high because of literacy rate and because of the access to sort of computers and other things that you require. But I think the social media has really played a vital role in making patients aware about the disease and how to look after themselves, about social distancing, and about the social messages that had to be given.
Thanks, Hussein. I was wondering, as you were presenting, and Alex too, how people in your countries are, if you're a family member or a caregiver, how are you staying in touch with people who are in the hospital? How are you taking care of your loved ones when they're in the hospital?
Yeah, I think it's again through mobile phones. So everybody basically has a mobile phone. So people are constantly in touch with their loved ones at the hospital, at their homes. So yeah, so it's basically mobile phones and the social media.
Yes, in Ghana here, since the virus is very contagious, the frontline workers will not allow you to visit your patient or your family. So like Jeffrey said, we use mobile phones and other things to communicate, because the Ghana Health Service has set aside a particular line that is a hotline for communication. So we are using the digital and other things to communicate.
Yeah, I think that is a really important point to make, that people all over the world have cell phones, and there's a lot that we can do in terms of communication with cell phones, and especially smartphones.
And the issue is, hello?
Please go.
And the issue in Ghana here is that most of the people, especially the women, do not have this kind of smartphones and the internet access. So it becomes difficult for them also to communicate. In addition, they do not have much experience or the knowledge about how to use this kind of digital system. So it's also another issue confronting our people, especially those who hard to reach communities, our rural people.
Is there a way to reach them with their cell phones, though, Alex? They have cell phones, but
yes.
not smart.
Yes. There's a way there are so many ways we can, link up with them in terms of, communication. For us, we go to the communities and use the information system, which is the community information system, to communicate with them. So we are also proposing, if possible, our government, should come out with initiatives that will enable most of our women to own their own phones, so that they will, be engaged in the digital world.
Yes, and Susan said, as mentioned in the chat box, that of course none of this applies to people with dementia. It's very difficult for them to use any kind of technological communication. So, Marty, you had something you were going to say?
Well, I was going to highlight Susan's comment too. She also mentioned, I think it was Susan or someone else mentioned people who are hard of hearing. So we just have these, special circumstances that the chat box has been really rich with suggestions on. The other question I had though was, we've given, pretty much all the presenters have given good ideas about how community groups are stepping up to get information out and support patients. But how are we supporting the caregivers? Family members who must be very stressed taking care of someone who's sick or worried about someone. What kinds of support are we giving to them? I mean, they might have to be quarantining someone at home.
Yeah, Marty, as I mentioned in my presentation, we have this helpline where people can basically call and get psychological help if they require, or any other support that they require. So we get, a lot of calls from caregivers, and especially the one that's for dementia, people with dementia. So basically, the most of the callers are caregivers who are getting under stress because of the caring burden, because of the lockdown and other things. So people are using this services there.
Great,
thank you.
Yeah.
Marty, it's Sharon, and here in Calgary, Alberta, possibly right across the country, there's been a lot of thanks going out and using the media to thank care providers, especially those working directly with COVID patients or those that could be exposed. But at a community level, at a city level, I've seen banners up. I've seen lots of people sending things into the hospital, but finding different ways of thanking healthcare providers, because without them available, our death toll and our critical incidence would be so much higher. So thank you for asking that.
So thank you for everyone. I think we are now at 90 minutes, and I would like to close the discussion, but I really appreciate this really great discussion, both in print and verbally. And thank you to all our speakers, to Neelam, to WHO, and to the Canadian Patient Safety Institute for hosting us, and to Marty for managing all the comments. So, unless anybody has anything else quickly, I will close the webinar, and thank you all for coming.